Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Okay, let's start with something pretty sobering. Imagine a silent killer responsible for 11 million deaths across the globe every single year.
11 million. That's a huge number.
It really is. We're talking about sepsis.
Yeah.
And what's terrifying is how tricky it can be to diagnose early, especially, in those vulnerable people, newborns, young kids under 5, pregnant women. The signs can be so vague.
They really can. Easily missed. Which leads you to wonder, isn't there a better way? Can we detect it sooner?
Exactly. And that's really what we're diving into today. We've been looking into this promising new possibility for catching sepsis early, a biological marker called interleukin-6.
Right, interleukin-6. We've gathered information from a few key places. There's a health news report from ESCMAD Global, that's from 2025, talking about a new study.
Okay.
Then there's a pretty comprehensive review article all about biomarkers and sepsis. That's from Clinica Chimica Acta, published August 2024. And also a specific research paper looking right at interleukin-6 in kids from the Pediatric Infectious Disease Journal back in August 2018.
Interleukin-6. Let me just spell that out for clarity. It's INTERLEUKIN space SIX. Okay, so multiple angles here.
Yeah, putting them together gives us a clearer picture.
And we know the current markers we use, they have limitations, right? They might be slow or not specific enough.
That's the problem. There's a real need for something better.
So the goal for this deep dive is really to get our heads around why interleukin-6 is generating this buzz. Why is it seen as a potential early warning system for sepsis? And we want to lay out the key info, without making it feel like homework.
Exactly. Let's start with that new study, the one from 2025. Its main aim was pretty clear: to see how well interleukin-6 could actually diagnose sepsis early on in those specific groups: newborns, children, and pregnant women.
So focusing right on those vulnerable populations.
Yes, and what's quite unique is that they looked at all three groups together in a real-world hospital setting, kind of a reality check for the biomarker.
Instead of just like isolated lab studies or focusing on only one group.
Precisely.
Okay, so how did they do it? What was the method?
Well, they did what's called a retrospective cohort study.
Retrospective?
Yeah.
So looking back.
Yeah, think of it like looking back through patient records and samples. They examined blood samples that had already been collected from 252 patients where doctors had suspected sepsis in the first place.
Okay.
And this group included 111 children, 72 maternity patients, and 69 newborns. So a decent mix across those key areas.
Right, so they have the samples. How do they then figure out who actually had sepsis versus maybe something else?
Good question. They categorized the patients based on a couple of things. First, the type of infection. Was it bacterial, viral, or could they not find an infection?
Makes sense.
And second, how the patient's body was responding. Was it a normal response, or was it something called systemic inflammatory response syndrome? SIRS, you might hear it called sometimes.
That's like the body's alarm bells going off everywhere, right?
Yeah, kind of, yeah. A widespread inflammation. Then they looked at actual sepsis. And finally, the most severe form, septic shock. These categories let them compare the interleukin-6 levels properly.
Okay, clear groups.
Mm-hmm.
So then how did they measure if interleukin-6 was actually any good at telling these groups apart?
They used a statistical measure called the area under the receiver operating characteristic curve. It's usually just called AUROC.
AURC sounds complex.
It does, but the idea is pretty simple. It basically tells you how well a test can distinguish between people who have a condition and people who don't. The score goes from 0.5, which is no better than flipping a coin,
Right.
up to 1.0, which would be a perfect test. So the closer you get to 1.0, the more accurate the test is.
Got it. Higher score, better test.
Yeah.
So what did they find? How did interleukin-6 do?
Well, the findings were actually quite encouraging. Across all three groups, kids, mums-to-be, and newborns, interleukin-6 consistently did better than the traditional markers they compared it against.
Which ones did they compare it to?
They specifically looked at C-reactive protein. That's C-reactiveprotein, and procalcitonin, spelled procalcitonin. Interleukin-6 was significantly better at telling the difference between bacterial infections, which are often the most dangerous in sepsis, and, other causes or no infection.
That's a big deal, right? identifying bacteria quickly is key for antibiotics.
Absolutely crucial.
Do you have the actual AUROC scores, just to get a feel for how much better it was?
Sure. For children, the AUROC for interleukin-6 was 0.91.
Okay, pretty close to 1.0.
Very good, yeah. In pregnant women, it was even a bit higher, 0.94.
Right.
And in newborns, it was 0.86. Still strong, significantly better than the other markers in distinguishing those bacterial infections.
So consistently outperforming the current standards.
Yes, and another key finding was that interleukin-6 also seemed effective at gauging the severity of the illness. It helped differentiate between, say, a milder infection, full-blown sepsis, and that really dangerous septic shock.
That ability to judge severity seems incredibly useful for deciding treatment intensity. What about sensitivity and specificity? How good was it at actually catching sepsis when it was there and ruling it out when it wasn't?
Good point. For the pediatric and maternal groups, interleukin-6 hit over 80% for both sensitivity, that's detecting the condition, and specificity, ruling it out correctly.
So pretty balanced performance there.
Very much so. And specifically for bacterial infections, the sensitivity was really impressive. 91% in children and 94% in pregnant women. It's finding it when it's there in those groups.
Those are strong numbers. But you mentioned the score was slightly lower in newborns, 0.86. Did that translate to sensitivity and specificity differences too?
It did, yes. For neonates, the specificity was actually very high, 97.1%.
Okay, so it's excellent at saying no sepsis if the baby doesn't have it.
Exactly. It's very reliable for ruling it out. But the sensitivity was lower, down at 67.6%.
So it might miss about a third of the actual sepsis cases in newborns.
Potentially, yes. It's less reliable for confidently saying, yes, this is sepsis in that group compared to ruling it out.
Why would that be? Any ideas from the researchers?
They suggested a couple of things. First, just diagnosing sepsis in newborns is notoriously difficult. There isn't one single clear definition everyone agrees on, which complicates things.
Right.
And second, sepsis can just look very different in newborns compared to older kids or adults. There's a wider range of presentations, making it harder for any single marker to be sensitive to all of them.
That makes sense. Newborn physiology is just different. So looking beyond the stats, what is it about interleukin-6 itself that makes it potentially better? Why does it react differently?
Dr. Sean Whelan, who led that 2025 study, explained it really well. He pointed out that interleukin-6 responds much faster and more dramatically to infection compared to C-reactive protein or procalcitonin.
Faster how?
Well, his quote was quite specific. Interleukin-6 secretion rises within 1 to 2 hours, peaks at 6 hours, and decreases by 24 hours.
Wow, peaks at 6 hours.
Yeah, whereas C-reactive protein and procalcitonin peak much later, around 48 hours for C-reactive protein and 24 hours for procalcitonin. He said, this faster, steeper response makes interleukin-6 a promising biomarker for earlier sepsis detection.
That time difference seems huge when every hour counts with sepsis.
Absolutely critical.
So is this just research talk, or is anyone actually using interleukin-6 tests in hospitals now?
Well, according to Dr. Whelan, they are. He stated that interleukin-6 testing is already in routine use at their hospitals, the Rotunda Hospital and Children's Health Ireland at Temple Street, specifically for these patient groups.
Oh, okay. So it's actually happening in practice, at least in some places.
Yes, it's moved beyond just the research phase for them.
What's making that possible? Are the tests readily available?
It seems so. A couple of things are helping. One is the development of commercially available tests that can run on standard hospital lab equipment, giving results relatively quickly.
Right. So labs don't need totally new machines.
Exactly. And Dr. Whelan also mentioned something interesting. The COVID-19 pandemic actually accelerated the use of interleukin-6 testing.
How so?
Because it became a more common test for assessing inflammation levels, the sort of cytokine storm idea, in COVID patients. So labs became more familiar with it, the tests became more widely available. That could smooth the path for its use in sepsis too.
Ah, an unexpected side effect of the pandemic, potentially helping with sepsis diagnosis.
Yeah.
Okay, so let's pull back a bit. Faster response, real-world use starting. What are the big picture implications if interleukin-6 becomes more widely adopted?
The biggest one, really, is the potential for much earlier intervention. That 2024 review we mentioned from Clinica Chimica Acta, it stated that for every hour treatment for sepsis is delayed, average survival can drop by about 7.6%.
7.6% per hour. That's staggering.
It really puts the need for speed into perspective. So if interleukin-6 helps shave off even a few hours, well, the potential impact on survival is huge.
Directly linking that faster biological response to potentially saving lives. What else? How might it change doctors' approaches?
Dr. Whelan suggested that wider use of interleukin-6, always combined with good clinical judgment, of course, could significantly sharpen clinical decision-making. It's another strong piece of data to guide treatment.
And what about antibiotics? Using them wisely is a big concern. Antimicrobial stewardship. Does interleukin-6 help there?
That's another really interesting potential application. Both the 2024 review and that 2018 pediatric study touch on this. The thinking is that interleukin-6 levels could help guide decisions not just on starting antibiotics, but maybe also on when to stop them.
How would that work?
Well, the 2018 study found that in children who were responding well to antibiotic treatment for sepsis, their interleukin-6 levels dropped significantly. So tracking those levels might show if the treatment is working effectively.
Like watching the levels fall is a sign the antibiotics are winning.
Exactly. But, and this is an important but, the 2018 researchers were careful to say that using it to decide when to withdraw antibiotics needs more study. You can't just rely on the number alone. The whole clinical picture matters.
Right. Makes sense. It's a guide, not an absolute rule. Now, that 2018 study also had a finding about different types of bacteria, didn't it?
Yes, that was quite specific. They found that interleukin-6 levels were much higher in children with sepsis caused by gram-negative bacteria compared to gram-positive bacteria.
Gram-negative versus gram-positive.
Mm-hmm.
Knowing the difference helps choose the right antibiotic, correct?
It can, yes. They found the median level for gram-positive was around 20 picograms per milliliter, but for gram-negative, it jumped way up to 127.
Quite a big difference.
Yeah, suggesting interleukin-6 might offer clues about the type of bacteria involved, potentially allowing for more targeted initial antibiotic choices.
Okay, so lots of promise. But we always need to talk about the limitations. Nothing's perfect.
Absolutely not. And we already touched on one major one, the lower sensitivity in newborns found in the 2025 study.
Right, it might miss some cases in that group.
Exactly. And the reasons for that, the diagnostic challenges, the varied ways sepsis presents in neonates, those remain limitations for using it confidently to rule in sepsis in that age group.
What other limitations should we be aware of?
Well, the 2024 review makes a really crucial point. Researchers have looked at over 200 potential biomarkers for sepsis over the years.
200, wow.
Yeah. And the reason there are so many is that sepsis is just incredibly complex and varied. Heterogeneous is the scientific term. Different causes, different patient reactions. It means it's really unlikely that any single biomarker will ever be the perfect standalone test for everyone.
So interleukin-6 is promising, maybe better than what we have, but it's not going to be a magic bullet that solves sepsis diagnosis entirely.
That seems to be the consensus, yes. It's a step forward, likely a valuable one, but probably part of a larger diagnostic picture.
Are there other things that can affect interleukin-6 levels besides sepsis?
Yes, definitely. Both the 2018 study and another review from 2022 mention this. Other inflammatory conditions can raise interleukin-6, and specifically in newborns, things like how premature they are, their metabolism, even just the stress of birth itself can influence the levels.
Ah, okay. So a high level doesn't automatically scream sepsis. Context is key.
Absolutely. The 2018 study also mentioned they had some limits analyzing results across different pediatric age groups because of sample sizes, so more data is always helpful.
Understood. So let's bring in some of the broader expert understanding of what interleukin-6 actually is and what it does in the body. That 2022 review seemed useful there.
It was. It describes interleukin-6 as a multifunctional cytokine, basically a signaling molecule for the immune system. It's a key player in that very early response to an infection.
How does it signal? What does it trigger?
It gets produced by lots of different cells when there's trouble, and it helps trigger things like fever and also the production of other inflammation markers like the C-reactive protein we've already discussed. The 2018 study also noted that link.
So interleukin-6 is like one of the first dominoes to fall, setting off other parts of the immune response.
That's a pretty good analogy, yeah. The 2022 review also notes it has complex roles. Sometimes it promotes inflammation, sometimes it helps calm it down. It's also involved in helping B cells mature, which make antibodies.
So it wears multiple hats.
It does. But when its regulation goes wrong, when there's too much or it's acting inappropriately, that dysregulation is linked to a lot of diseases, and sepsis is definitely one of them.
A case of too much of a normally good thing causing problems. How did the experts in these papers compare interleukin-6 directly to the other markers?
Well, the 2018 study, focusing on children, found that both interleukin-6 and procalcitonin were better diagnostically for sepsis than C-reactive protein when each was used alone.
Okay, confirming what the newer study found as well.
Yes. And interestingly, they also looked at combinations. They found that using interleukin-6 together with procalcitonin actually gave the highest diagnostic accuracy in their pediatric group.
Ah, so maybe the future isn't just one marker, but using a panel, combining their strengths.
That seems very plausible based on this research. It could give a more robust picture.
Okay, this has been a really thorough look at interleukin-6. If we boil it down, what's the main takeaway message?
I think the core message is significant potential. The evidence, especially from this latest 2025 study, really suggests interleukin-6 could be a very valuable tool for spotting sepsis earlier, particularly in those vulnerable groups, newborns, kids, pregnant women, where we know early diagnosis is just critical. That faster response time is its key advantage.
But with caveats, right, it's not quite ready for universal prime time just yet.
Exactly. While it's encouraging that places like Dr. Whelan's hospitals are already using it routinely, more research is definitely needed. We need broader studies in different settings, diverse populations, just to really confirm these findings and figure out the best way to implement it widely and reliably.
And always remembering it's a tool, not the whole answer.
Couldn't agree more. That point came through strongly. Biomarker results, whether it's interleukin-6 or anything else, have to be interpreted within the full clinical picture. They support, but don't replace, the expertise of doctors and nurses assessing the patient directly.
Right, so thinking ahead, as we get better at understanding the incredibly complex immune reactions in sepsis, and we develop these newer, faster tools like interleukin-6, it does make you wonder, doesn't it? How might this fundamentally change how we tackle sepsis, especially for the most fragile patients?
That's a powerful thought.
And what other doors might this open? What other avenues for even earlier detection or maybe different kinds of interventions could emerge from these kinds of advancements? Definitely something to keep watching.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.